This morning's general session will cover the evolving transplant landscape. There's quite a bit going on in the transplant arena, and that is an area that is of great interest to patients. And this morning, we're going to have several experts provide us insights from their perspective about what their organizations are involved in with respect to transplantation. Now, ladies and gentlemen, we're going to hear from Dr. Lloyd Ratner. Dr. Lloyd Ratner, a good friend of the American Association of Kidney Patients and a frequent guest who has provided information in webinars and has always been available to answer questions that we may have. Dr. Ratner is the Director of Renal and Pancreatic Transplantation, Department of Surgery at Columbia University Medical Center. He's the immediate past president of the American Society of Transplant Surgeons. And he is going to provide us information from a transplant professional perspective. Dr. Ratner?
Hi, my name's Lloyd Ratner, and I am a professor of surgery at Columbia University in the city of New York, and I am the director of the Renal and Pancreatic Transplantation program here. The AAKP has asked me to talk today about strategies to decrease kidney discards, which I'm happy to do. Unfortunately, I don't have any relevant financial disclosures. I do have a fiduciary disclosure in that I am the immediate past president of the American Society of Transplant Surgeons. However, all the opinions expressed in this presentation are strictly my own and don't represent those of any other organization, including the American Society of Transplant Surgeons. I'm going to talk about a number of strategies to reduce the kidney discard rate. And these are to reduce risk aversion, to improve allocation efficiency, to improve provider and patient education, to have a more realistic assessment of donor quality, and to provide a safety net for patients with suboptimal outcomes. And then I'm also going to tell some suggestions for policy strategies, which I think would help in these regards. So it's important to understand that there is a complex transplant ecosystem consisting of referring physicians and dialysis providers, donor hospitals, organ procurement organizations, transplant centers, payers, the organ procurement and transplant network and the allocation scheme, and regulatory agencies. And these interact, as you're going to see, and have an impact on whether or not we utilize or discard kidneys for transplantation. Now, as you're probably aware, the number of kidneys that are being procured and are being discarded from deceased donors has increased over the last decade, or the last 2 decades, and now we're at about 20% or greater of the kidneys that are procured from deceased donors are being discarded. It's important to understand how the allocation system works in order to understand why kidneys are discarded. Now, the allocation system uses a construct called the Kidney Donor Profile Index, which basically what this is, it tells us a percentile ranking of the quality of the kidney in terms of its expected graft survival, so the kidney survival over a 1 and 2 year period. And it uses a multivariate analysis, and you can see the variables that go into this multivariate analysis. But what's important to know is that there's a percentile ranking that gives you the quality of the kidney. The higher the percentile ranking, the worse the quality of the kidney, the worse the expected outcomes. It turns out that a very large percentage of these kidneys that are discarded are the high KDPI these high KDPI kidneys. And you could read the caption there. It says, "I've got good news and bad news. We found a donor, but the guy was 104 years old." Well, obviously that's not going to be optimal. If we look at the discards by KDPI, which is the percentile ranking, the absolute numerical value given to kidneys is what's called the KDRI, but let's stick our discussion to the KDPI. So if we look at a KDPI of 85% or greater, about half of those kidneys that are procured from donors that fall into that KDPI range are discarded. Okay, 50% of those kidneys are discarded, which is, a huge amount. If we're going to increase the number of organs available, the large increase is most likely to come from the organs at the margin or from the donors at the margin. Now, if you look at the graph on the left, and there's a table within that graph, you can see, though, although 50% of high KDPI kidneys are discarded, 50% of the discarded kidneys are from donors that have KDPIs less than 85% or greater. So what would seem like good kidneys are being discarded as well. This is a picture. You can see a gentleman, that's Sumit Mohan. He's one of my colleagues at Columbia University. And we published this finding that the discard of kidneys varies by day of the week. And those with the discards being greater on the weekend, and the kidneys that are discarded on the weekend tend to be of better quality than those kidneys that are discarded on weekdays. Okay? It's like there are more bad kidneys on the weekends. The discard rate goes up, meaning we have to discard kidneys that are of better quality. Now, that implies that it's not just the quality of the kidney that is factoring into why these kidneys are being discarded, but rather organizational and operational factors at the level of the transplant center that impact whether or not kidneys will be discarded or not. Dr. Mohan and our group went on to publish another paper which also shows that there is huge geographic variability in the chance of getting a kidney and utilization of organs. And this graph shows broken down into the 11 UNOS regions. But you could see the vertical bars also show the variability between centers within a given region. And you could see there's very wide variability from one center to the next, whether someone will get transplanted, and correspondingly, whether or not they'll utilize organs and whether or not those organs will be discarded. So again, there's a systemic problem here. So let's start with the first issue, and that's that of risk aversion. Well, currently, the regulatory environment that looks at transplant center performance looks at outcome measures, and they focus on 1 year patient and graft survival. Important in that is that there's an imperfect risk adjustment. So we get compared to the national average. They try to risk adjust based on the quality of the donor and how sick the recipient is. But the risk adjustment is a little bit better than a coin toss. The problem is further compounded by the fact that it's a punitive system. So if you get flagged as being performing less than expected, you get punished or can be punished. And there's no incentives to utilize suboptimal kidneys. There's an imperfect risk adjustment, so it doesn't, all the factors that go into why a kidney is not optimal to use doesn't go into the outcomes measures, and so you could only get hurt if you go out on a limb and use a suboptimal kidney from the standpoint of the transplant center. Now, there are also financial risk aversions. Recipients of these suboptimal kidneys are generally harder to take care of and tend to be more expensive. They have longer length of stay in the hospital. Many of them, and I'll show you some data about this, need for post-operative dialysis, which is more expensive. And yet there's no differential payment for whether or not you're going to use a suboptimal kidney versus an optimal kidney. And so centers with narrow margins are disincentivized to utilize these suboptimal kidneys, which then leads to their discard. There are a number of things which will impact a center's risk tolerance and or aversion. things like the risk of primary non-function or delayed graft function. Primary non-function is when the kidney never works. Delayed graft function is when the patients require dialysis after the transplant until the kidney recovers. Whether or not they ever get to optimal function or whether they just kind of sputter along suboptimally and only give, sort of partial function to the recipient. Whether or not they're expecting to have a shorter graft survival. If they've been injured in some way and are likely to bleed, which make it more difficult to manage the patient. If they're at risk for ureteral or vascular complications, or if they're at risk for transmitting diseases like HIV, hepatitis C, parasitic diseases, cancers, et cetera, et cetera. So all of these things factor into why centers may have risk-averse behavior with some kidneys. This is a very famous graph. This was published by Jesse Schold from the Cleveland Clinic, who basically looked at centers and looked at their outcomes. And the top line, line number 1, shows the patient survival in those centers that consistently perform better than expected. The second line is the patient survival in those centers that consistently performed as expected. And the third line is the patient survival in those centers that consistently performed less than expected in terms of their outcomes. Okay? Those centers that are likely to be flagged for suboptimal performance. But when you compare that to the fourth line, which is those patients who are transplant candidates on the waiting list who don't get transplanted and remain on dialysis, you can see the patient survival is hugely better, even in the worst performing transplant centers. Well, why is that so important? Well, because again, those centers fall into a punitive system. And Schold then went on to further show that anytime a center gets flagged for having suboptimal or low performance under expected, then in general, their volume of transplants decreases by about 30%. So making it more likely that they'll discard organs and making it more likely that they won't take on difficult patients. Let's talk a little bit about allocation efficiency. Well, the allocation algorithm is complex, but to a large extent, it's driven by waiting time. People with long waiting times are unlikely to accept suboptimal kidneys. So, for instance, I call up Mrs. Jones and I say, Mrs. Jones, we have a kidney for you. We have a wonderful kidney for you. You've been waiting 8 years. And she says, oh, Dr. Ratner, I'm so excited. But is this a good kidney? And I said, well, yes, this is a very good kidney, but 90% of kidneys are better than it because it's a 90% KDPI. Who would wait for 8 years and then accept that kidney when maybe 2 weeks or a month later, they'll get a much better donor kidney? Okay, so then we go to the next person on the list, same discussion, on down the list, okay? And as that goes on, as we keep offering the kidney to more and more patients, the amount of time it takes, the clock is ticking. So the longer the kidney is outside of a living human being, the greater the chance it won't function appropriately. So these long allocation times make suboptimal kidneys even more suboptimal. Then you get to the point where you have transportation logistics, and these are problematic. And so if you can't allocate it to someone locally and you need to make a broader net to send to and try and get it allocated nationally, well, the kidneys fly on commercial airlines. And, so if there are no flights available because now you've spent the last 6 hours trying to allocate the kidney and now it's 8 o'clock at night and there are no flights until the next morning, you've just added an additional 12 or 14 or 15 hours onto the kidney. These long allocation times are often compounded by lack of flights and long logistical delays. Now, my point here is that, these wind up, because we're talking about trying to have equity and those patients who have waited the longest should get the first shot at the kidneys. Well, my point is that if these kidneys aren't going to be utilized, there's no utility. Without utility, then equity is moot. So we should have a much more efficient allocation system, which could get these kidneys to people that would actually use them. Well, let's talk about these hard-to-place kidneys. Well, this is a paper from a paper that my group has recently submitted that looked at hard-to-place kidneys. Now, UNOS defines hard-to-place kidneys as those where you go down to the 100th person on the list or greater to get this kidney accepted. Okay, so we looked at those kidneys that were transplanted into patients 1 through 7 on the list, 8 through 100, and then we looked at the hard-to-place 101 to 1,000. And then we looked at these super hard to place where we went down greater than 1,000 patients on the waiting list. And if you look at the highlighted yellow areas, the first area that you see is the cold ischemic time. So you could see that the hard to place kidneys, 100 or greater, have about 10 more hours of ischemic time outside of a living human being, than those sort of optimally placed kidneys. And if you go to the super hard to place kidneys, they're about 15 hours for the other ones and 18 hours for the super hard to place kidneys. So we're sort of hurting these suboptimal kidneys even more. And that's reflected in the outcome. So if you look at the bottom yellow boxes, the PNF stands for primary non-function. Those are kidneys that never work. It's about a 3-fold difference between these hard-to-place kidneys that are more likely to be discarded, and the delayed graft function, in other words, needing dialysis following transplant, is about twice as much. So again, making it more difficult to place these kidneys with suboptimal outcomes, although these outcomes are still very, very good. But in our current punitive system, there's risk aversion because of that. Overall, these generally tend to do well, and you could see that although there is a statistically significant difference in terms of the outcomes for the hard-to-place kidneys, which are the lower 2 lines, versus the upper 2 lines, which are the easier-to-place kidneys, the outcomes are still quite acceptable and way, 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 way better than on dialysis. So let's talk about provider and patient education. Well, there's that of organ acceptance. Well, I think, like I tried to explain to you with the issue of the KDPI, the consent and allocation process are pejorative to the kidneys. We have to disclose all these facts about the donors, whether they were at risk for contracting other illnesses and things like that. Kidneys for transplantation are sort of like used cars. You can never get a brand new one right from the factory. Some will have more mileage than others. Some have been maintained better than others, but you're never going to get a perfect one. I think another misunderstanding is that the degree of HLA matching is of limited significance, and the risk of disease transmission is really extraordinarily low, even in those people who have social behaviors which would make them seem like they're at risk for developing diseases like HIV, hepatitis C, etc. What we really need, and we have some, are prognostic tools that tell us, number one, what's the chance of dying on the waiting list? What's the likelihood of getting a better kidney offer? How long will it take to get a better kidney than the offer currently at hand? And how can these tools realistically be incorporated into the real world situation? Because when I get a kidney offer at 3 in the morning and I may be operating, there's no way we could go and look into these calculators, and it's unlikely that the patients will utilize them either, and we have very limited time to make decisions about this. So we need more realistic utilization of tools like this. So let's talk about a safety net for patients with suboptimal outcomes. Well, if a kidney fails early on, the patient will get their waiting time back. But there are no accommodations for kidneys that never function well but kind of continue to sputter along. So, if we look at glomerular filtration rate, maybe someone will get a kidney where the glomerular filtration rate is only about 22 or 23%. It may keep them off dialysis, but that's not much better than an end-stage kidney. So there's no real incentive for patients to accept a kidney like that. Patients should be prioritized if they accept a suboptimal kidney that either fails early on or functions poorly. There is a precedent in terms of the safety net for liver transplant recipients who have kidney disease who may also be candidates for a kidney. But now, if they just get the liver transplant, they are prioritized to get a kidney later on if it turns out that they really need a kidney transplant. I think we also need a more realistic assessment of donor quality. I talked a little bit about the risk adjustment. Well, things like high KDPI, donors at extremes of age, elevated creatinine versus acute kidney injury, or long ischemic times, those go into the risk adjustment. But things that don't include comorbid conditions, pathologic features when you look at the kidney on a biopsy. If you put them on a perfusion pump, we could use those pump parameters, the flow rates and resistance within the pump as prognostic factors, the risk of disease transmission, and whether or not the kidneys, what I call, are anatomically incorrect. Do they have any procurement injuries or injuries from the cause of death, like a motor vehicle accident, tumors, whether they have anomalies, congenital anomalies, and whether they have multiple vessels. None of that goes into the risk adjustment or the assessment of donor quality, but they do go into our assessment of whether we use them or not. Well, here's my favorite philosopher, Yogi Berra. He said, if people don't want to come out to the ballpark, how are you going to stop them? That was in the time when television first came out and people were watching TV rather than going to the ballpark. So the Ratner corollary is, if people don't want to transplant kidneys, how are you going to stop them? Well, I think we need to change performance metrics to assess the entire continuum of care with an intent to treat analysis that looks at evaluation, listing, pre-transplant, transplant, and post-transplant, and that'll encourage people to utilize more kidneys. What I call dealing from the bottom of the deck, and that's that if we give the suboptimal kidneys to the patients with short waiting times rather than the patients with long waiting times, this will mitigate the suboptimal outcomes of these high KDPI kidneys. It's difficult to do this with our current allocation system, and with these kidneys, recipient selection is critical. So the idea is to give the suboptimal kidneys to the patients with the shortest waiting times who are unlikely to survive to get to the point where they'll be getting better offers. And then finally, what I call the wildcard solution. And this is to encourage listing of patients. We would say that a percentage of those patients who get listed can receive the wildcard designation, maybe 5%. So a wildcard designation will exclude patients from the overall performance metrics. But you would have to designate this wildcard prospectively before transplant. So what that would do is would encourage transplant centers to transplant patients with risks not included in the risk adjustment, but also to be able to utilize kidneys that are not accounted for in the risk adjustment. You just declare it prospectively and say, okay, I'm going to transplant this kidney into this patient, and they're going to be a wild card patient, be removed from the performance metric. It would also encourage cohorting of patients with difficult problems, and it would encourage innovation and experimentation. So I think that's a good way to solve a bunch of problems. So in summary, there are a number of interrelated factors that lead to kidney discards. Current policy does not discourage the discard of kidneys. Risk aversion and allocation inefficiency play important roles in organ discard. Reduction of kidney discards will likely result in suboptimal outcomes, but those suboptimal outcomes will be better than the alternative of not being transplanted. And there are a number of policy approaches to addressing this problem. So I'd like to thank the AAKP for allowing me the opportunity to address you today, and I wish you all good luck.
Thank you, Dr. Ratner. Thank you for that very insightful presentation. Thank you for all that you do for patients.